All right, well, thank you everybody for joining today's webinar, Acute Intermittent Porphyria, an overlooked but treatable inherited neuropathy. My name is Susan Hepworth. I'm the Executive Director of the Clinical Neurological Society of America, and I will be hosting today's webinar. After my brief welcome and introductions, I will do an overview of CNSA's clinical proceedings, and then I will turn it over to our speakers today to review the white paper highlights on this particular topic. We have saved time at the end for question and discussion, so feel free to use your Q&A button at the bottom of your screen to submit a question at any time during today's program, and then we'll get to those questions at the end. Very pleased to be joined today by three excellent presenters who are joining us. Dr. Manisha Balwani from the Icahn School of Medicine at Mount Sinai. We're also joined by Dr. Mohammed Kazamel from the Mayo Clinic, Arizona, and also by Dr. Bruce Wang from the University of California, San Francisco. Just a little bit about CNSA. CNSA was founded in 1974, and it welcomes neurologists, advanced practice providers, and other allied health professionals as part of its membership. CNSA's mission is quite simple, and that is to improve clinical practice and patient care through education and thought leadership, which is exactly what we will be doing today as we review the highlights of this clinical proceeding white paper. So what is a clinical proceeding? Well, a clinical proceeding is a series of informational resources that are intended to raise awareness and address unmet needs in neurology that exist. A clinical proceedings is a white paper that is authored by a series of experts, three of whom we have with us on this webinar today. And then the outputs of a clinical proceedings include a white paper, webinar like we're hosting today, a lot of digital advertising and social media graphics, and generally distribution of expert knowledge. We do recognize the financial support was provided for this particular clinical proceeding from Recordati. I will just recognize here the other expert panelists who were part of this paper. And with that, I will go ahead and turn it over to our panel to present today's slides.
So my name is Mohammed Kazamel. I'm a neurologist at the Mayo Clinic in Arizona, and I would like to thank the Clinical Neurological Society of America on adopting this project and helping us with the production of it. I also would like to start by thanking my fellow panelist experts, especially Dr. Balwani and Dr. Wang, on their significant help with this white paper and the presentation. Today, we are going to talk about acute intermittent porphyria in particular, and this is a rare genetic disorder caused by deficiency in one of the enzymes that are responsible for the heme biosynthesis. We're talking specifically about hydroxymethylbilane synthase enzyme that is responsible for the third step of the production of heme, and this deficiency in that enzyme typically leads to episodic attacks of autonomic peripheral neuropathy and also central nervous system complications. And that's why, as neurologists, we should be involved in the diagnosis and management of that disease. In general, the disease is quite difficult to diagnose for several factors that my colleagues will talk to you about today, including the rarity of the disease, the fact that it is not on our radar as neurologists when it comes to the differential diagnosis of acute episodes of paralysis that present to the ER, and we get consulted about those patients by our ER colleagues. The reason why it has become important for us not to overlook that disease is because there are available options of treatment now. And this is a disease that's one of the very, very few peripheral neuropathies that are inherited, and we have treatment for. As you guys know, most of the inherited neuropathies, including Charcot-Marie-Tooth disease and hereditary sensory autonomic and hereditary sensory autonomic neuropathies are not treatable, but this one is in particular, we have a treatment for, and we don't want to mess in our clinics or in the hospital or during the hospital stay. The burden of the disease and the long-term complication is something that I dedicated a separate slide for, and I will talk to you about it. And the cost of missing the diagnosis is quite hefty for us as a medical community, and also more importantly for our patients. And in general, I will finish by talking about the importance of raising awareness to the importance of multidisciplinary management of the disease. Typically, we would like our patients to be managed by several specialists, including a neurologist, hepatologist, geneticist, physical therapist, as part of PM&R, and several other multiple medical disciplines. So to kind of talk about the nervous system, the peripheral and central nervous system manifestations of the disease that matter to us as neurologists, we would like to divide them into central and peripheral nervous system manifestations. And the peripheral nervous system manifestation, for me as a neuromuscular specialist, I would like to talk about what is peripheral neuropathy and what is autonomic neuropathy. Talking about peripheral neuropathy during an attack, typically those patients present with motor predominant peripheral neuropathy leading to weakness and paralysis, typically of acute onset during the luteal phase of the menstrual cycle. Typically, those patients present to us in the ER with upper and lower limb, proximal more than distal weakness, and that is affecting mainly the upper limb rather than the lower limb. And that's, to some extent, help us like think more porphyria rather than other acute onset motor weakness presentations that we see more commonly in the ER, like Guillain-Barré syndrome. It also could affect the 3, 7, 9, and 10 cranial nerves, leading to bilateral facial paralysis, very similar to Guillain-Barré. Also, there is like paresthesias more distally in the hands and the feet, but also they can have a bathing suit distribution on torso. When it comes to autonomic neuropathy, which is something that it is similar to Guillain-Barré, when it comes to that, those patients typically present with the most important feature of an acute attack, something that the patient would make sure to let you know about, which is excessive excruciating abdominal pain in the setting of a very unremarkable workup, including abdominal ultrasounds and CAT scans in the abdomen. So we, as people treating porphyria in general, consider abdominal pain as a manifestation of autonomic neuropathy, in addition to resting tachycardia, orthostatic hypotension, nausea, vomiting, urine retention, typically what we call sensory atonic bladder. These are the peripheral nervous system manifestations of a porphyric attack. During the attack, we could also have manifestations of central nervous system involvement. Typically, these are anxiety, depression, insomnia, in addition to seizures in 20% of the acute attacks. And we're going to have to be very careful with treating those seizures because not all of our medications, our anti-seizure medications, are safe in porphyria. Some of them, in fact, could induce a porphyric attack or even make it worse. In addition to that, many patients complained about blurred vision, and you could see Babinski sign, which of course is something that you could not see in Guillain-Barré. Other things that are outside the realm of neurology that we should be alert for is the abdominal pain, as I mentioned earlier, and also the dark urine. And the dark urine is not in all patients during the attack. So these are, and also in addition to that is the hyponatremia. Typically, those patients have a sodium of around 130. So this all alert us to the notion that we are dealing with a porphyric attack rather than any other etiology of acute onset motor weakness like Guillain-Barré. So again, anytime you see a patient that you suspect having Guillain-Barré, if they think about asking them about acute abdominal pain, think about asking them about darkening of the color of urine. Think also about asking them if they had a previous episode like this, because typically we know that Guillain-Barré is not that recurrent, while porphyria attacks could be recurrent. And after I talked about the general manifestations of an acute attack of porphyria, I would move to the next slide, and my colleague, Dr. Manisha Balwani, will talk to us about epidemiology.
Thank you, Dr. Kazamal. So most of our understanding about the epidemiology of acute intermittent porphyria comes from studies in Europe. And they have noted that symptomatic AIP affects about 6 to 15 per 1 million in their population. Most symptomatic patients are female, and in acute intermittent porphyria, over 80% of symptomatic patients are women. These attacks typically begin after puberty. We also know from studies done in using exome databases, as well as studies done in healthy blood donors, having a pathogenic variant in the HMBS gene, that's the gene involved in acute intermittent porphyria, that's not very rare. So about 1 in 16 to 1,700 in the Caucasian population will carry a pathogenic variant or likely pathogenic variant in the HMBS gene. So based on the frequency of the pathogenic variant and the number of symptomatic patients, one study estimated that only about 1% of these variant carriers will actually develop symptoms. Now, it's not difficult to imagine, since you just heard about the very variable presentation and symptoms from Dr. Kazamal, that many of these patients may actually be undiagnosed or misdiagnosed. So the number of symptomatic patients may be an underestimate. We also know from studies done in France that if you have a symptomatic family member, the disease may be more penetrant, and it may be more common in families which already have a symptomatic family member. So with that, I'm going to turn it over to Dr. Wang.
All right, thanks, Dr. Balwani. Okay, so what we're seeing here on the right is the heme biosynthesis pathway. This is a pathway that has 8 different enzymatic steps, as shown here on the left, that takes the starting materials glycine and succinyl-CoA through 7 pathway intermediates until you eventually make heme. In AIP, what we're talking about today is the most common acute porphyria. It's the 3rd step in this pathway with the enzyme that's encoded by the gene HMBS that is partially defective. And that, as a result, can create a bottleneck in this biosynthetic step, and that can create an abnormal accumulation of the pathway intermediates delta aminolevulinic acid, or ALA, and porphobilinogen, or PBG. And I will highlight that these 2 compounds are porphyrin precursors and not porphyrins. This will come back a little bit later when we talk about diagnosis and what types of tests to order. But ALA and PBG, and of the 2 in particular, we think ALA specifically are quite toxic to nerve cells. And we think that it's the abnormal accumulation of these porphyrin precursors that are responsible for the wide range of symptoms that occur during acute porphyria attacks. Now, Dr. Balwani just mentioned that only a small percentage of mutation carriers actually develop symptoms. And even in patients who do have acute porphyria attacks, their attacks are not constant, right? They are intermittent, which also gives rise to the name of this disease, acute intermittent porphyria. So if this step, enzymatic step, is mutated all the time, is defective all the time, why don't people have symptoms all the time? Well, it's because the rate limiting step in the heme biosynthesis pathway is actually the very first enzyme. It's not written on here, but that particular enzyme, enzyme 1, is ALA synthase 1. And that rate limiting enzyme, its activity level is even lower than even the defective enzyme activity in HMBS mutations. And so for most people, who have HMBS mutations, most of the time that mutation is masked, and we don't actually see it becoming a bottleneck. In liver in particular, and hepatocytes, they can have significant changes in the demand and the level of heme demand. And so in the liver, the activity level of the first enzyme, ALA synthase 1, can vary considerably, and it can be increased significantly. In those settings, now that the effective third step becomes the rate limiting step, and that's the setting in which you can have abnormal accumulation of ALA and PBG. And I think next, Dr. Balwani will talk about some of the situations where that can occur.
Thank you, Dr. Wang. So as Dr. Wang said, the first enzyme in this pathway, ALAS1, is critical. And in AIP, which is an autosomal dominant enzyme deficiency, we typically need another factor, precipitating or triggering factor, which causes stress down the pathway. So this can be either resulting in direct upregulation of ALAS1, which is the first and rate-limiting enzyme in the pathway, or it can result from hepatic heme depletion, which causes indirect upregulation of ALAS1. And this slide lists some of the most common precipitating or triggering factors. In young women, typically progesterone-containing contraceptives are a very common trigger. Drugs are a very common trigger, and as Dr. Kazamal mentioned, some of the anti-seizure medications can also precipitate acute attacks. Fasting or dieting, alcohol consumption, smoking, infection, stress, surgery can all lead to acute attacks. So I also want to mention that maybe in a first initial acute attack, you may be able to identify a clear trigger, but very often for our patients who have recurrent attacks, we may not be able to identify a subsequent trigger. And we'll talk a little bit about management of these patients and avoidance of these precipitating and triggering factors later on. And with that, I'm going to turn it over to Dr. Kazamal.
Oh, I think this is
Dr. Wang.
I think this is my slide. Okay, all right. So we've talked a little bit about how AIP is a genetic disorder of really incomplete clinical penetrance. And so we can further classify AIP patients clinically based on their manifestations. So as we've talked about, the vast majority of mutation carriers, probably upwards of 98 to 99% of mutation carriers, never experience an acute attack in their lifetime. Those patients in this table here, we're classifying under the category of latent AIP. They were never going to have attacks during their lifetime. And the chronic symptoms and long-term complications, including long-term chronic neuropathy symptoms, renal dysfunction, which we think may be related to having a history of attacks and high levels of ALA and PBG. And then the third long-term complication I'm going to talk about, I'll mention, is increased risk of liver cancer. All of those chronic effects, long-term complications, are not well studied in the latent AIP patients, but in general, we think that these patients are not at risk of those chronic effects and long-term complications. Now, about 1% to 2% of mutation carriers will have acute attacks in their lifetime. And the vast majority of those people, greater than 90% of them, based on epidemiological studies, will fall under the category of sporadic acute intermittent porphyria, meaning that they're going to have a small handful of attacks during their lifetime. Most of these people, when they're having these few attacks during their lifetime, are very likely to have, if we take a careful history, one of those inciting factors, inducing factors that Dr. Balwani just mentioned. These patients are typically do not have many of the chronic effects, especially the chronic neuropathy, especially if the few acute attacks that they do experience are treated promptly. But there is some evidence that they may still be at risk of having long-term renal dysfunction and have increased risk of liver cancer. So these patients probably do have to be monitored more often long-term compared to the latent AIP patients. Now, lastly, we have a small subset of patients, of those who have acute attacks, but who have frequent recurrent attacks. That's typically defined as having more than 4 attacks per year. This constitutes about likely less than 5% of the patients who have acute attacks in their lifetime. As is mentioned here, the exact number can be highly variable of the number of attacks they have per year. Some patients may have attacks on a weekly basis. These patients are at the highest risk of developing chronic complications and chronic effects of acute attacks, including long-term chronic neuropathy, renal dysfunction, and increased risk of liver cancer. And it's important that these patients, their attacks be treated promptly, and that they should all probably be considered for prophylactic treatment for prevention of attacks, again, to minimize the long-term chronic effects of acute attacks.
Thanks, Dr. Wang. So I wanted to discuss in this slide the burden of the disease and how much will it cost us as a society and also the patients if we don't appropriately diagnose and manage those patients in the early during the course of the disease. Actually, if we were to talk about this, we can be divided before diagnosis and after diagnosis, and the suffering of those patients typically start before the diagnosis, when they start having acute attacks, and then they have these excruciating episodes of abdominal pain, and they visit the ER day after day during one of those episodes, and the ER doctors do not find anything in their objective clinical exam or investigations with negative imaging, and those patients are requiring typically narcotic medications for their pain relief. And many of our patients have reported to us formally and informally that they have been labeled with drug-seeking behavior, which worsen their anxiety and depression over time. Once the diagnosis gets established, which may take, as we will mention later, up to 15 years, those patients typically continue the journey of investigation and treatment. And sadly, in between the attacks, they continue to have chronic symptoms too. In fact, in one of the studies, or actually in two studies, we verified that 2/3 of our patients in between the attacks continue to report symptoms of chronic neuropathy, especially in the recurrent group that Dr. Wang talked about. And basically chronic tingling, numbness, low back pain, neuropathic pain, in addition to chronic abdominal pain, nausea and vomiting, and all of that. And obviously these symptoms limit the quality of life for those patients. In addition to the chronic symptoms, there are also the chronic complications that Dr. Wang alluded to, including the chronic kidney disease that may start as early as the age of 35 in 15% of patients. And another study also found this in about 2/3 or 60% of patients as they got older. The risk of liver cancer is there, and many of those patients would be required to continue ultrasound surveillance on their liver. In addition to that, as a neurologist, I always also try to take care of their anxiety and depression and all of that, and the insomnia that could precede the impending attack. And these are also chronic manifestations of the disease that adds to the burden of the disease on the patient. When it comes to the financial and the economic burden of the disease, we will also need to talk about the cost of taking care of the disease, which could range between $135,000 to $600,000 per year for patients who are on prophylactic treatment to prevent further attacks from happening. We would also highly indicate that those patients get the disease in the young working years of their life. So in one of our studies, we reported that about 13 out of 19 total patients were unemployed, and 3 more patients were working part-time. And of course, the burden of medical bills in the setting of unemployment could not be imagined for those patients. I would also mention that even before the diagnosis, those patients, when we counted their visits to the outpatient clinic and their hospital stay, both of those items were significantly increased in porphyria patients when compared to the general population. So this is quite burdensome disease when it comes to the quality of life, the state of employment versus unemployment, and it also puts great financial burden and economic burden on the patients and their families, and the constant fear of developing complications or even developing an impending attack is always with these patients, leading to more anxiety and depression throughout their years.
So one of the, some of those long-term complications we know can be decreased with prompt diagnosis and treatment. This then highlights one of our issues here with this disease, which is it is oftentimes missed and diagnosis is very delayed from the time of onset of symptoms. On average, that is upwards of 15 years. That is true here in the US as well as in Europe. Why is that? If we look on the potential barriers to diagnosis, much of it is because of the rarity of the disease, in that there is lack of awareness on the side of healthcare providers to think of this disease. There is also the fact that the presentation of the symptoms are not specific to acute porphyrias, and that if we can see that the differential diagnosis include many other more common kinds of conditions. And so it is not, acute porphyria is not considered as a possibility. In fact, making the diagnosis of acute porphyria is relatively straightforward. This is one of the diseases where we understand the pathophysiology quite well. We know what causes the symptoms of acute porphyria attacks. And the way to do the test is to do it biochemically by looking for high levels of ALA and PBG. Typically, urine PBG is the first line test that is checked because the levels are very high and that you can detect it reliably even in a random urine sample. You do not need to do a 24-hour urine collection. You don't need to do blood tests. That should be the first line of testing in anyone you're suspecting of having an acute porphyria attack. The other thing I will mention here is that those patients with frequent recurrent attacks that we talked about as a separate category, the small number of patients, those are patients that are having symptoms on a regular basis. So if you have a patient that comes in that you suspect of having acute porphyria, who's having symptoms that look like acute porphyria symptoms on a regular basis, those patients typically have very high levels of ALA and PBG detectable in the random urine, even in between their attacks. So in those patients, again, a baseline urine porphobilinogen level can be very useful in making the diagnosis. And if normal, can probably rule them out for having frequent recurrent attacks. All right. Genetic testing is useful, but is useful as a second line confirmatory testing and to differentiate acute intermittent porphyria from the few other acute hepatic porphyrias, variegate porphyria and hereditary coproporphyria, which are less common than AIP. This does speak to one of the other barriers to diagnosis. Even though I mentioned making the diagnosis is very straightforward, we can do it with spot urine testing looking for ALA and PBG. Currently, there is in the US, there is a lack of readily available rapid ALA and PBG testing. So as a result, oftentimes these patients, when they're presenting to the healthcare system, are presenting in the acute care setting, an urgent care clinic, or more often, an emergency department. And the currently available urine testing for ALA and PBG typically take at least 3, sometimes up to 5 to 7 days to come back because these are all sent out tests. And so that's another reason, even though the correct test and an accurate test is available, it is oftentimes not done because a rapid test is not available.
So I'm going to switch gears now and talk a little bit about treatment and management. And the first goal of treatment in acute intermittent porphyria is to do no harm, so to avoid the triggers we spoke about. So we spend a lot of time counseling our patients about the precipitating and triggering factors, asking them to cross-check medications for drug safety, asking women who are on hormonal contraception to choose alternate methods, avoidance of alcohol, stress, dieting, or fasting. As we mentioned, patients can still continue to have acute attacks even where an identified trigger is removed. And if patients have an acute attack, which leads them to go to the ER or the hospital, these acute attacks can be treated with IV hemin. And IV hemin works by reducing the levels of ALA and PBG and decreasing the upregulation of ALAS1, which is the first enzyme in the pathway. So the typical hospital course for these patients is a daily treatment with IV hemin, 3 to 4 milligram per kilogram given daily over 4 days. And usually by day 2 or 3, we start to see a clinical response in these patients, also leading to a reduction in their use of pain medication. But really, the better way to treat patients is to avoid acute attacks altogether. These acute attacks can be very disabling and they can take an extremely long time to recover from, and patients will often have residual symptoms and need rehabilitation. So the way we give prophylactic treatment has evolved over time. This can be done by hemin, which can be used outpatient at an infusion center, and we can give it to patients on a regularly scheduled basis to avoid acute attacks. So patients can get IV hemin on a weekly or monthly basis to prevent attacks. You can also give hemin on demand, which is when patients have early signs and symptoms of an acute attack. If they have access to an infusion center, they can come and get an infusion as an outpatient, and that method has been successful for some patients. In the past few years, there's been approval of a novel treatment called givosiran. This is a siRNA therapy which targets hepatic ALAS1, and by targeting hepatic ALAS1 and downregulating it, it decreases the amount of ALA and PBG and prevents attacks. So this is another successful strategy in avoiding or preventing acute attacks. And I really want to stress, and we've heard this throughout the presentation, that this is actually a chronic multisystemic condition. And while the name is acute intermittent porphyria, this should certainly be treated as a chronic disorder. And multidisciplinary care is needed for the management of these patients. So as you've heard, these patients can have chronic pain, nausea, fatigue, they can have hypertension, and they need to be monitored by a group of specialists for optimal care. Next slide.
So in conclusion, I hope that I and my colleagues managed to convince you of the importance of diagnosis and early management of this still rare, inherited, but treatable condition. We tried through this presentation to raise awareness of the importance of diagnosing acute attacks when we as neurologists get consulted by our ER colleagues in seeing a patient of acute onset motor weakness or quadriparesis in the ER, try to differentiate whether this is Guillain-Barré or acute intermittent porphyria. Typically, as I said, acute intermittent porphyria patients come to the ER multiple times, while Guillain-Barré is once in a lifetime occurrence disease in 95% of patients. Also, Guillain-Barré, as we all know, is an ascending disease involving the lower limbs before the upper limbs, while the weakness in porphyria typically involves the upper limbs more than the lower limbs. I would say also in acute intermittent porphyria that the anchor reflex is typically preserved, unlike any case of Guillain-Barré where it is typically lost. Nerve conduction studies are typically demyelinating in Guillain-Barré patients, while they are axonal in porphyria, and the CSF studies are normal in porphyria, while there is increased protein in Guillain-Barré. So these are like 5 or 6 very important differences between the most common presentation, two of the common causes of acute onset motor weakness. I would like to stress on the cost of missing a patient with AIP when it comes to diagnosis, because these patients continue to develop chronic symptoms in between the attacks if they are left untreated, and also are liable to develop chronic complications like essential hypertension, chronic kidney disease, and liver cancer over time, in addition to the psychiatric complications, of course, including anxiety, depression, and all of that. So that really reflects the cost of delayed diagnosis for those patients, which, as my colleague Dr. Wang indicated, could come to up to 15 years of delayed diagnosis. And these are the best years of our patients' life in the working years, because the disease could start in early adulthood and getting forward. We have tried to improve our methods of diagnosis over the years, and we no longer require like 24 hours of urine for the ALA and BBG. However, we do believe that the best practice to improve our methods of diagnosis is actually put the disease back on our radar as clinical neurologists, as clinicians in general, by thinking more porphyria. One of the sad stories for one of my patients that she was admitted for a presumptive diagnosis of Guillain-Barré, and after they tried plasma exchange and IVIG during clinical rounds in the morning in neurology, the idea of porphyria came actually from a medical student, because they are the ones who still remember about the disease from the medical school years. So we need to raise awareness of that disease and raise awareness of the importance of early treatment, because this remains to be a form of toxic neuropathy, and prolonged exposure to ALA damages the nerves over time. Early treatment is likely to improve patients' lives when it comes to decreasing the chronic symptoms, and also preventing further attacks from happening, because every attack happens increase the liability of the patient to have more residual symptoms and more motor weakness and more autonomic neuropathy over time. So the final message is, please put porphyria on your radar, especially if you are going to see a patient with acute onset motor weakness with acute abdominal pain in the setting of dark urine and hyponatremia. And with that, I am very, very grateful to the Clinical Neurological Society of America and for my colleagues in the panel. And we would like to welcome any questions from the audience.
Yes, thank you so much, Dr. Cozumel, Dr. Balwani, and Dr. Wang, for a very thorough, excellent presentation of acute intermittent porphyria. Just as a reminder, we have about 5 minutes for questions, so folks can go ahead and put those in using the Q&A button on their screen. And I've already got a couple of questions here, actually, so we will get started, and I'll kind of open it up to any of you who would like to answer this one. Obviously, we heard in here the importance of the multidisciplinary care team, but there can be challenges to the coordination of that. So do any of you have any best practices or insights you would like to share about better coordinating the multidisciplinary care team?
So I can try that. So at our center, we definitely work with different specialists to coordinate the care for these patients. And I think this is challenging because we have restrictions like insurance and all of that to deal with as well. But for most part, we try to refer to the same provider all the time, and we regularly stay in touch with these providers and update them on the literature as well. And we've been very fortunate to find excellent partners in the care of our patients. And I think that model is really needed for all of these chronic multisystemic conditions.
Okay, we have Dr. Cozumel, you ended by saying everybody needs to have this on their radar if they are presenting with certain symptoms. But how can we do a better job raising awareness of AIP? And to what audiences do you feel like need that the most education or the most reminders about AIP and its symptoms?
I would argue that neurologists should come on the forefront of this because the presentation of the attack and the presentation of the chronic symptoms in between the attack are typically either somatic motor neuropathy or autonomic neuropathy. So I would think that, like in the Porphyria consortium, most of my colleagues are hepatologists and geneticists, so they know about the disease, but it is my job to kind of like, or our job to get better education about the disease and raise the awareness of the disease among neurologists. And also the second group of specialists that we will need to kind of like direct our attention to is ER physicians when it comes to detecting the attack and being like more alarmed to the if you are an ER physician who is on a night shift and you see a patient that comes to you with acute abdominal pain and you do all of your workup, comes back negative, and then on the next night you are again on call and the same patient is coming to you because the IV pain medication that you gave her last night did not work, and or the effect of it has went down. Like if you see that pattern, this is not typically a pattern of a drug-seeking behavior, rather than we need to be giving those patients the benefit of the doubt and testing them for urine porphobilinogen, which will take time. And again, that is a significant barrier to the diagnosis, but at least I want to say that the ER physicians and neurologists should put this disease on the radar more than the current situation.
Okay. Excellent. We just got another question in here. They ask, can these chronic or neurological symptoms occur after 2 attacks, or is it nothing to worry about?
I'm happy to take a stab at that question. I think it really actually depends on the severity of each individual attack. I think we've seen, I think the 3 panelists on today, we've probably seen each of us have seen a wide range of presentations and severity across different patients of individual attacks. I can tell you I've had patients who on their first initial presenting attack have had a very severe prolonged attack that, combined with it being unrecognized, can lead to bulbar paralysis, respiratory paralysis. And I've had a case where that occurred in a young person, and that person had really prolonged disability for many years from after just having that first attack. On the other hand, we've also had patients who have shorter self-limited attacks of lasting few days, a week or so. And in those cases, those patients after the attack, they may have little residual symptoms after a recovery period, which can oftentimes take many weeks to several months before they fully recover. And in those patients, they may not have any long-term sequelae from it. So it really depends on the severity of those attacks.
Okay. And we do have time for one more question. We just got one more in here. Is IV glucose still recommended for patients during attacks?
So I can try that. So first, for any patient whose attack is severe enough to go to the ER or the hospital, the treatment of choice is Heman. We typically give patients IV glucose till the Heman is being mixed, but IV glucose is not a substitute for panhematin. Heman gives a much better recovery, a much faster recovery. And as we've heard from Dr. Wang, that these patients can be quite debilitated if they're not treated correctly. So with IV glucose, the attack may still progress, and these patients may develop debilitating symptoms. So Heman is the right choice for a severe attack, but certainly these patients also have severe nausea and vomiting. So giving IV glucose while you're also supporting them with Heman can be done.
Great, thank you. Well, that is all the time we have for Dr. Kazimel, Dr. Balwani, and Dr. Wing. Thank you so much for a very excellent presentation today. And just to let everybody know who's watching today's webinar, we will send a follow-up email with a recording of this, as well as a link to read the white paper. So thank you so much for your time, and we hope everybody has a great afternoon.
Thank you, everyone.